Hello, thank you for attending our webinar. Today's webinar is Making a Difference in Opioid Addiction Treatment. Today we're going to highlight a success story from Evergreen Treatment Services. I'm Carrie Dostey, the Director of Marketing here at AMD Global Telemedicine. So our featured presenters today on the webinar is Ron Emerson from AMD. He's the Global Director of Strategic and Partner Development. And we're being joined today by Dr. James Darton and Tina Andrews from Evergreen Treatment Services. Dr. James Darton is a medical internist and the Flex Care medical provider for their program, and Tina Andrews is the Flex Care program manager. A few housekeeping things. As you have questions, please feel free to type in your questions into the panel on the right-hand side of the GoToWebinar dialog box. You can type them in throughout the meeting or at the very end when we have our Q&A session. We will take 15 minutes at the end to address as many questions as we can. But if we don't get to them all, of course, please feel free to reach out to the presenters individually as well with some of your questions, and we'll have their contact information posted at the end as well. So today, we're going to cover quite a few things, some things from the regulatory Department of Human Health and Services, what their top 5 priorities are for opioid crisis treatment, the Haight Act and the Special Registration Telemedicine Act of 2018. And Evergreen Treatment Services is going to talk to us today about different opportunities that they've had to increase their patient volume and address patients by leveraging telehealth technology. More specifically, they're going to talk about their Flex Care program, in which they've leveraged some telehealth in that program as well, and what the benefits have been to them, what the outcomes have been, how they've leveraged it, what they've done with it, and how they've seen it made a difference in patient care. So first, I introduce Ron Emerson.
All right, thank you very much, Carrie, and I'd like to thank everyone for taking time out of your busy schedules to join us. So we're going to talk about some key issues today. The first thing is we're going to talk about the Department of Health and Human Services top 5 priorities. We're going to talk about something that's near and dear to everyone wanting to utilize distant technologies to take care and to help folks with substance abuse, which is the Haight Act and Special Registration Act, which is new of 2018. And then we're also going to describe and give you an overview of how telemedicine is leveraged for treatment. So as I go to the first slide, let's just talk about the 5-point strategy that HHS has for the opioid crisis. The first one is to improve access to treatment and recovery service. So I think we all realize and we can all appreciate, and while we're on this call today, that there's a direct correlation between access to care and quality of care. And you're going to see that even more specific and some great examples of that later on in the presentation. Promoting the use of overdose reversing drugs, promoting a better understanding, so more education and understanding of the epidemic, and then also looking at cutting edge research on pain and addiction, and then advancing better practices for pain management so we don't have as many people that go through this difficult issue. So a disclaimer, I'm going to talk about the Haight Act, and the first thing is I'm not an attorney. I have a bachelor's degree in nursing. I've been doing telemedicine for over 22 years now. And of course, we run across this quite frequently, but just a disclaimer that you must not rely on the information of this webinar, of course, as an alternative to you getting legal advice from your attorney or from a professional legal service provider. This session, it's really about providing just an overview of the regulatory and policy items pertaining to Haight Act and telemedicine, and then also just giving you an update on the Special Registration for Telemedicine Act of 2018, which was recently signed by President Trump, and I'll give you some specifics on that. So something we're all very familiar with is the Haight Online Pharmacy Consumer Protection Act. So for those of you that aren't, of course, just going back a ways, it was really developed to address the rogue internet pharmacies in the late 90s. They were selling controlled substances online. And really what it came down to was they actually passed the act. It occurred on April 13th, 2019. 2019, and that's the day that the DEA started to enforce it. And what really happened is they basically required that a prior in-person exam take place, right? So you couldn't, online pharmacies and all of these other things couldn't happen. You actually had to have an in-person physical exam before being able to prescribe controlled substances. But there is something that a lot of folks aren't aware of, is that there was actually an exception to that, and it contains an important exception to the in-person exam requirement for practitioners engaged in the practice of telemedicine, and there's actually 7 of those. All right, there's 7 of those, and we're going to cover one of those. So if the practitioner or patient, and that's one of the 7 practice of telemedicine exceptions that you can prescribe controlled substances without an in-person visit first. So let's talk about the Haight Act practice of telemedicine exceptions. So the first one is if the patient is being treated in a hospital or a clinic. And this is more specific to the practice of telemedicine is being conducted while the patient is being treated by and physically located in a hospital or clinic registered under, and it basically has the section for the designation of a clinic or a actual hospital. Okay, if you're treated in the physical presence of a practitioner, and this is the practice of telemedicine is being conducted while the patient is being treated by in the physical presence. So it basically provides that in the usual course of professional practice. So this is basically an in-person visit with a physician with them, and then you have someone from a distance sometimes coming in, which also helps as well from a clinical perspective, helping providing guidance. If you're part of Indian Health Service or a tribal organization is another exception. Public health emergency is declared by the Secretary of Health and Human Services. And then number 5 is a very, very important one, which we're going to come back to because this basically has something to do with the new law that was just recently signed by President Trump, which is special registration. Okay, so the special registration has been around since they actually initiated the Haight Act, but this special registration has not actually been put into place. Okay, Department of Veteran Affairs and Medical Emergency, that's one of the exceptions, and then other circumstances specified by regulation. All right, so those are the 7 exceptions, and as Evergreen talks about their program, they'll talk about how they use it and how they're using it underneath these situations. But just be aware, though, I think the thing is that that you have to realize that there's federal law and then there's also state law. So look at your individual state laws for these things as well, and then also, of course, be aware that even if you have one of these exceptions, that you have to continue to practice and engage and basically authorize and follow the typical rules that you would anyhow, even without telemedicine. So that's important. And so what's the issue with this, and why are a lot of folks excited about what just happened with the signature of the new legislation we're going to talk about in the next slide, is that it's limited in scope, right? And the example given is, of course, you'd have to have a patient site presenter that might need to be registered with the DEA. The patient has to be physically located in the presence of a practitioner, or they have to be in a hospital or in a clinic, right? Or a DEA registered facility. And these are some of the things that are important. And also has some limitations on the originating site of where the patient can actually receive services. And as you can see, it does not bode well for direct-to-consumer. So a lot of times we have patients that are in rural areas that if we could reach out to their homes and provide different types of care and medication management under a direct-to-consumer model, we would increase care and we could impact the outcomes that we have. And Carrie?
Great. Thanks, Ron. Okay, we're just going to ask a quick poll question. How familiar are you? Let me just bring this up. Sorry. How familiar are you with, I'll launch it in a second. Sorry. There you go. How familiar are you with the bill President Trump recently signed, the Special Registration for Telemedicine Act of 2018? If you go ahead and put your answers in, I'm aware of it, I understand how it will affect my organization, or I'm not aware of it. And this will just get a help gauge our audience today and figure out who needs a little more explanation versus less. Give it a few minutes for everybody to put in their answers. Okay, I'm going to go ahead and close the poll. Oh, no, we still got, yeah, I'll go ahead and close the poll. It looks like we have most people answered. Share the results here. We have 36% said that you're aware of it, 2% understand how it will affect their organization, and 62% are not aware of it or what it means. So great, because Ron is going to share with you what it means.
All right, wonderful. I'll advance. Okay, so we talked about Ryan Haight. We talked about the 7 exceptions that those of you that are currently using telehealth or virtual technologies to provide care. And let's talk a little bit about the special registration for Telemedicine Act of 2018. As I talked about, if you look at the 5th exception, it's a special registration. This was never enacted. And President Trump signed into law on October 25th, so just very recently, that requires the DEA, the Drug Enforcement Agency, to activate the special registration clause, which allows physicians and nurse practitioners to prescribe controlled substances via telemedicine without an in-person visit initially. Okay, so this is a really big step for us, but we're, as I said, October 25th, we're in the very beginning phases of this, so we don't know exactly what that's going to look like yet. And the other thing that it will address, so it'll require them to look at physicians and nurse practitioners, but it will also address originating site eligibility. Okay, so we can reach people where they need the care. Now, what is this going to look like? The honest answer is, in all the research that I've done, and I say this is very new, and I'll give a shout out here to the folks, gentleman by the name of Nathaniel Lackman, who is with Foley and Lardner, who just does an amazing job of providing information and is a real advocate for telehealth. And from a legal perspective, of course, he's an attorney. And the information that they're basically providing is saying that there's going to be from the 25th, there's going to be a 60 to 90 days for publics to submit comments. So people need to submit your comments if you want to. And once you submit your comments on what it should include, what it shouldn't include, what concerns you have, and then basically the DEA has 1 year to issue a final registration. Okay, so this is not done. So from now until a year, or whenever the DEA actually gets the final registration complete, you could still practice under the 7 exceptions that we talked about. And then, of course, we'll have the DEA will activate the special registration for physicians and nurse practitioners to be able to prescribe controlled substances underneath this act. So this is a really big move for us, and we're really excited in the industry, but there's still some unknowns of exactly what it will look like. And as I said, Foley and Lardner, I have no relationship with them at all. I just, they're just real advocates. They just do a great job with telehealth, posting a lot of stuff. And for those of you that want more information, even if you just go to LinkedIn and look at Nathaniel Lackman's site on there, he has a lot of great articles about this and does a really nice job of articulating the information. So saying that, that's where we're at from a regulatory perspective, and we can dig a little bit deeper into that if you have questions, and I can answer things that I'm comfortable with at the end that's appropriate. But how are organizations that we work with, and of course you're going to get a great example from Evergreen, how is telehealth being leveraged? First thing, for those of you that are very new to this, what is telehealth? Telehealth basically means the transfer of electronic medical data. That can be real-time video. It could mean direct to consumer, where a patient's in their home and they're like on their phone talking to a clinician. It could be where a patient's in a clinic or a hospital, like we talked about one of the exceptions, and you can use biometric data. You can look at eyes, ears, you can get pulses. It can be a variety of things. It can even be store and forward technology. But when we're talking about substance abuse and counseling and helping with different things, what we're really talking more about is live video connections. And then sometimes when they need it, of course, they can use biometric vital signs, or you could just do it manually to get them over to the provider on the other side. So some of those use case scenarios are, how do you connect to pain management specialists? So how do we in rural areas connect people to clinicians who are expert in this area, so people don't become dependent on these medications with some of these chronic pain issues that they have? And that's one of the use cases that we see quite frequently. Another one is substance abuse counseling. substance abuse counseling, a lot of times, of course, substance abuse, a lot of rural areas, and how do we provide counseling to these people where they're located? And then a lot of times with that substance abuse counseling, as we'll have the good folks from Evergreen talk, they also work with a medical physician, and they do medication management at the same time. I've also using the technology and seen it for group therapy, and also support programs like 12-step programs are being used, which some people might not designate as pure telehealth, but we're seeing this being used, and it's definitely an important component of helping people that are struggling with this issue. So as I talk a little bit more about telemedicine, on the left-hand side, sort of the diagnostic, so the clinician could be at any location. You could have a card or some other device in a clinic, in a hospital, in a rural area, a treatment center, and the clinician could come over that means, and then we talk about direct-to-consumer, which is actually connecting into the home. Now, with that, I think one of the things that was really interesting to me as a great transition as we prepared for this is a lot of the great looking at the PowerPoints, a lot of the great data that Dr. Darnton and Tina provided for us to look at, which talks about this crisis, and it's just very clear just the correlation between access to care and quality to care as a parent. And I'm really excited for you folks to listen to some of the good information they have to say. So based on that, I want to introduce Dr. James Darnton. He's an internist with Evergreen Treatment Services, and Tina Andres, who's the Flex Care Manager. And we're going to start out with Dr. Darnton. So it's all you, sir.
Great. Thank you, Ron, and thanks, Carrie. And thanks for inviting us to share about our clinic and our successes and challenges using telehealth to provide substance use disorder treatment in Washington State. As Ron said, I'm a primary care doc based in Seattle and provide I'm an addiction medicine provider with Evergreen Treatment Services. And Tina, who is our program manager, and I are going to tell you a little bit more about our program, but I want to start at a 10,000-foot view with a little epidemiological context, and I won't belabor this because I know that all of you in providing healthcare in any capacity have lived experience with some of the effects of the opioid epidemic on our patients. But I think it's important to keep some of these facts in mind. Among them, that we're in the midst of an overdose and drug epidemic that's pretty unparalleled in our history. This is a graph from the New York Times, which shows overdose deaths over the last 30 years, which have increased precipitously, and a graph showing treatment admissions for opioid use disorder, neonatal abstinence syndrome, ED presentations for complications of opioid use would have a similar slope. You can see here that the deaths have surpassed peak gun deaths, peak HIV deaths during the height of the HIV epidemic, peak car crash deaths, and now actually the leading all cause of death for Americans under the age of 50, and 2/3 of those are due in at least in part to opioids. And geographically, no part of the country is spared. In our region, in the northwest corner, there is no exception. This again shows increase in overdose deaths per 100,000 in the population from 1990 to 2015. What this map doesn't demonstrate, but which is important to understand, is how it's really rural and suburban areas that are where the epidemic sort of first took hold and that are still the hardest hit. And of course, for a variety of reasons, among them that accessing treatment in those areas is very difficult. Which brings us to the treatment gap for substance use disorders in general. NIDA estimates 22 million folks in the country with a substance use disorder. About 10% actually receive evidence-based treatment, and it's similar percentage for specifically dealing with opioid use disorder. And while increasing, there's currently a minority of providers, physicians, nurse practitioners, and PAs have undergone the training and licensing process to prescribe buprenorphine, which is the medication that's used in the office-based setting. And just a few words briefly on efficacy of medication-assisted treatment with buprenorphine, or methadone, or Vivitrol, the 3 FDA-approved medications for opioid use disorder. Without any of those medications, abstinence-based treatments, relapse rates are very high. This is actually a generous graph. Many meta-analyses show a relapse rate over 90% at 3 to 6 months after abstinence-based therapies. And then contrasting with a medication-assisted treatment, here that we're looking at buprenorphine, retention in treatment represented by the blue line here, over time, about anywhere from 50 to 60% of people remain in treatment after a year, which is clearly not a silver bullet, but a lot better than abstinence-based treatment. And you can see the longer people, as represented in this green line, the longer people stay in treatment, the more they're able to abstain from using illicit opioids. But of course, the outcomes that we really care about are greater than just retention and treatment. And there's been numerous high-quality studies showing a pretty dramatic decreased mortality from access to treatment with medication-assisted treatment, specifically with methadone and buprenorphine. We haven't seen enough data to support that for Vivitrol as of yet, but so you can see here, setting the kind of general population mortality rate at 1. Folks with an opioid use disorder have about a 6-fold increase in mortality when they're not in treatment, and that mortality can be cut by 2/3, over 65%, by being engaged in treatment with pharmacotherapy. So, I challenge you to think of another medical intervention with such a dramatic effect on mortality rates. But of course, you need access to treatment to have any of these benefits, and that's a challenge throughout the country, and has been a challenge in our state, particularly in the rural areas that are hardest hit. So I'm going to turn things over now to Tina, who's been with our program from the beginning as we tried to address some of these access issues and describe some of the challenges we encountered and kind of how we tried to forge ahead.
Thank you, Jamie. I'm Tina, and I'm from the Grays Harbor area, the Hoquiam Clinic. Evergreen Treatment Services has been in existence since 1973, transforming the lives of individuals in their communities with innovative and effective addiction and social services in Western Washington. They currently operate 4 opiate treatment programs, OTPs. They have 2 units in Seattle. They have the South King County Clinic. In Olympia, they have the South Sound Clinic. And at Grays Harbor, they have the Grays Harbor Clinic in Hoquiam, Washington. We're currently treating about 3,315 patients with medicated assisted treatment. The traditional OTP programs require a daily attendance for medication administration and is governed by strict federal regulations. So the patients need to come in every single day to get their medication. People who live far away cannot make it to the clinic every day for dosing. Furthermore, the clinics were operating at capacity like most OTPs in the country. Originally, they had patients from our area, which were about 20 minutes, 15 miles from the ocean here on the West Coast, and people were traveling 2.5 hours to Seattle. When they finally opened up the clinic in South Sound, which is still 1 hour and 15 minutes away, that took a lot of time, and people weren't being very successful because of the distance. So then they opened up our clinic here in Hoquiam, And so the people who live far away couldn't make it to the clinic every day. Between gas, lack of transportation in our rural communities, the buses don't even run on the weekends. So how could they get their medication on Saturdays? So ETS came up with the prescription-based buprenorphine treatment program, which we call FlexCare, to allow patients the flexibility to pursue their employment, be able to spend more time with their lives, and engage in other recovering activities. In the end of 2015, ETS was awarded the SAMHSA grant. It was called the MAP-PADOA grant, which the funding began in 2016. What they found is there's a lack of waiver providers. At that time, there was one provider in our area that was maxed out, and people couldn't get into treatment. And so when they got this grant, we needed to find waivered practitioners who had were certified to provide buprenorphine at these remote clinics. And that's where telehealth came in.
Okay, thank you, Tina. Let me just, we've got another poll question for you. Give me a minute. So we wanted to find out how many of you are currently using telehealth for addiction treatment at your organization? Go ahead and put in your answers, and I'll wait a few minutes. It looks like some of you are still voting. I'll give it a few more. Okay, I'm going to go ahead and close the poll and share the results with you. So it looks like 27% of you are currently using telehealth and 73% are not, or not yet anyhow. Okay, I'll pass it back to you, Tina.
Thank you. Wait, Jamie, thank you. Whoops. Can you back up one, Jamie? So, how telemedicine is used. This is about our program, how we are using it. So the way our program works is the patients are seen weekly for the first 4 weeks. We use the medication management. We use buprenorphine. We do weekly drug testings and then counseling and motivational interviewing. We provide the buprenorphine prescription. We send it directly to the pharmacy for the patient. Patients making progress in treatment, we go full weeklies and then every other week for 2 months, and then they can, if they're stable, can move on to monthly prescription monitoring. Each of our sites has a program manager, a nurse care manager, and a medical assistant, and the telehealth machine. So our physicians are located from us about 2.5 hours away. We have one physician that's in Seattle, or two in Seattle, and one in Oregon. They conduct the initial assessment, quarterly follow-ups, dose evaluations, medical consults, whether it be on pregnancy, chronic pain, relapse, surgeries, if they're continuing to use opiates or other illicit drugs. The majority of routine follow-up visits are conducted by the nurse care manager. She will see, based on the Massachusetts model. It's been very effective here at our facility. The medical assistant assists the physician with the telehealth visits, taking the vital signs, operating the telehealth machine, and providing the patient's information, handouts, and arranging referrals or follow-up visits.
Okay,
Jamie,
great. Yes, yeah. Let me jump in here. So we have some data for you on our program. As Tina mentioned, we were part of a grant that awarded funds to 3 clinics, and 2 of them were operated by Evergreen Treatment, and the majority of visits were conducted via telehealth. The third one was a program at Harborview Hospital, an urban safety net hospital in Seattle that provided a more traditional in-person office-based opioid treatment program that was embedded in a primary care clinic. So it's actually kind of a nice natural experiment as we look at the data that we're able to compare some of the outcomes of our programs where telehealth was employed and the program at Harborview where it was not. This slide shows data from all 3 clinics, just looking at the demographics of the patients that were involved, and probably similar to the demographics in your clinic and kind of reflective of the opioid epidemic as a whole, largely young white men. You can see kind of the racial breakdown, gender breakdown, and age breakdown here. And most of our patients are in their late 20s, early 30s, but we do have patients at the extremes of age range as well. Looking at folks, their substance use prior to intake, pretty similar across the sites and probably similar to what you guys are seeing in your communities, about a third, anywhere from 30% to 42% use heroin as their drug of choice. We have a smattering using heroin and illicit prescription opioids. This group here represents folks using illicit prescription opioids only. And then we had anywhere from 20 to 30% of folks who developed an opioid use disorder while on prescription opioids for chronic pain. So slight differences between Harborview and our 2 clinics, but pretty similar breakdown as far as substance of choice. We also take a screening test for all of our patients at intake, and you can see the comorbidity with mental health disorders. So, north of 2/3 of the patients had moderate or severe depression, as reflected by a score of 10 or more on the PHQ-9 screening. Similar numbers reported symptoms consistent with moderate to severe anxiety and PTSD. So looking a little bit at, for now moving on to outcomes, we tracked the number of inductions. So these were folks that actually received medication, came to their initial visit, had their screening, and actually were started on medicine, on primarily buprenorphine in almost all cases, though some patients did opt for Vivitrol or Depo-naltrexone. And you can see that Harborview, the in-person, more traditional program is represented in red, and our 2 programs are here in the paler colors. But essentially, we were all able to induct a similar number month by month and met our grant goals. Actually, well surpassed our grant goals for number of patients to induct to start on medication. And then, of course, another outcome of interest is retention in treatment, and we don't break it down by clinic here because it was so similar. But basically, we had at 6 months a 59% retention in treatment and 50% at a year, without significant differences between the different clinics. And again, as you recall from the earlier slides, that's right about average for office-based buprenorphine retention and treatment outcomes from peer-reviewed studies. We do have a list of reasons for discharge here, and it's primarily people who are just sort of lost to follow-up that just stop coming, and we do outreach, but some people either move or relapse or are incarcerated, and we lose them to treatment. We tried to minimize interruptions in treatment surrounding an involuntary discharge, though we did have a handful of those. So just to kind of summarize in plain language, we through the use of telehealth and allowing these waivered providers, that was really the kind of rate limiting step. And we had counselors, we had nurses, we had MAs. It was the medical providers with license to prescribe buprenorphine that were in short supply. And through the use of telehealth, we were able to treat about 60 more patients a week. Of the 315 patients, pretty much all of them have had a telehealth visit at some point. Initially, it was, all of the visits were telehealth, though as time has gone on, we've actually recruited and trained up more in-person providers. So I think now the split's about 50-50 when the patients have a medical visit, whether it will be a remote provider via telehealth or an in-person medical provider. And each clinic each week spends about 8 to 10 hours of provider time over the telehealth machine, and we're able to see anywhere from 4 patients an hour to 2 patients an hour for doing new inductions. And as I showed on those prior slides, our outcomes as far as ability to actually perform inductions and to retain patients in treatment is similar to the traditional in-person program where the patient is seeing a provider in the examination room, kind of in a more traditional model. I should note the majority of our inductions are home inductions, so we're kind of instructing the patient on how to safely start the medication on their own, and they're kind of going home and doing it, which is how a lot of programs are operating now, and there's good evidence that that's an effective way to start people on medicine. So I'll turn things over to Tina once again to talk a little bit about patient satisfaction and some other features of the program.
So one of the most interesting and what I'm most pleased with is of the 300 patients that we're currently seeing, the 800 that we've seen, we've never had a patient decline a telehealth visit. My experience with the patients, they've been excited. They enjoy it. I don't see any difference from the inpatient visits or the telehealth visits. The patients seem to enjoy both of them just the same. And I spoke a little bit earlier about that Evergreen Treatment Services. We do have 3 addiction medical providers and 1 PA that are providing care at our clinics, who wouldn't be able to access the clinics without telehealth. 3 of them are in Seattle and 1 is in Oregon. It would take him 3.5 hours to get here from Oregon to see the patients, and with telehealth, he can spend 3-4 hours and see a lot more patients than if he was having to travel to ours. It's the same with the South Sound Clinic. Without telehealth, we wouldn't have been able to see the patients. Some of our patients come from, we've covered 13 different counties between South Sound Clinic, Grays Harbor Clinic, and Harborview. We have the patients that are from Clallam County. They drive 2.5 hours just to get to the Grays Harbor Clinic. And without the telehealth to be able to see the providers from Seattle, they would never have been able to engage in this OBOP program. And so without telehealth, we would lose so many more patients that aren't able to make it to the daily program or even to Seattle to see a provider. Very pleased to be able to cover 13 counties. Currently, we're in the process of converting from the grant funded to self-sufficiency. Our grant ended July 31st, so the last few months we've been moving over to being reimbursed for the medical visits to make this program self-sufficient. Salaried medical providers do not have to commute nearly as far. Like I said, 3 hours to see patients at this clinic, 2 hours at the South Sound Clinic. We would never be able to afford those providers or have the access to the good quality providers if it wasn't for telehealth. We are currently billing the insurances for the medical provider visits. The one thing we've been struggling with is the nurse care manager visits, which is a big percent of our program, but we are now beginning to be able to be reimbursed for those services. And so now we're going to show you a few of the people.
Thank you, Tina. We were kind of thinking of future applications for telehealth and telemedicine. As Ron mentioned, the patients are physically located in our pre-existing opioid treatment programs, formerly known as methadone clinics, which are DEA registered clinics. So we're exempted under the Haight exemptions for that reason. But were we able to expand and get an exemption to prescribe a controlled medication without an in-person visit in alternate settings? I mean, it would really improve ability to deliver care. And just spitballing, being able to extend to community mental health agencies, primary care clinics where the providers aren't providing treatment, jails. We have a lot of our patients have interactions with the criminal justice system, and treatment can be interrupted during periods of incarceration. But it also provides an opportunity for initiating treatment. If we were able to leverage, telehealth in those settings, and maybe even home visits someday. Another potential use that we have not yet done, but I think could be really helpful, is integrating mental health and primary care via telehealth with addiction medicine services. So, we do have a lot of patients who have a hard time, for similar reasons, accessing primary care and mental health in some of the more rural counties, and they benefit a lot from their addiction treatment. But if we could integrate that with other forms of care, I think we'd see pretty good results. Great.
Okay, so now we're going to open it up for questions. If you haven't done so already, there's a there's a panel on the right-hand side that you can type in some questions. Feel free to just add additional ones as we go. It looks like we do have a couple already to start. So let me just pull them up here and we'll begin the Q&A session. Okay, here one question is, do you only do telehealth from clinic to clinic, or do you do clinic to patient's home as well? And I think you might have just touched on the future direction stuff, but I don't know if you want to also address that, Dr. Darn.
Yeah, sure. I wish. I mean, that would be really a helpful thing to be able to do to access the patients. That currently, at least as we understand the law, as Ron described it, the patient has to physically be located in a DEA registered clinic in order to use to legally prescribe a controlled substance without an in-person evaluation. Now, if the patient has had an in-person evaluation and been given the diagnosis of opioid use disorder, I believe you can have subsequent visits over telehealth in alternate settings. But I'd want somebody to parse the legal language more closely. We don't currently offer those services in settings outside of the patient being physically located in a DEA registered clinic.
Okay, thank you. What type of examination or diagnostic devices are generally required for a telehealth encounter?
Well, one thing I'll say right off the get-go for our program is, one, we have a screening tool we use prior to the patient being assessed by a chemical dependency professional. Once they're diagnosed, then they're set up for a nurse care visit, and then they will see one of our medical providers like Jamie, and he can tell you what they do then.
Yeah, and as far as physical exam and lab and other diagnostics, we'll have, and I think it's key to emphasize, I think the crux to the key to this working is really having a medical assistant on with the patient who can work hand in glove with the remote provider to get things done that need to be done. So we'll have our patients all undergo urine drug testing every visit, and it's a point of care immunoassay, and the medical assistant will describe the results to me or the remote provider at the beginning of the visit. The medical assistant also takes vital signs and for a new patient measures pupillary size and reports that as well. We do get baseline lab blood testing that just kind of we document through our EHR, and it doesn't really come into play with telehealth. And then as far as the physical exam, other than the vital signs, I'll typically document a mental status exam just based on my interaction with the patient, questions I've asked the patient, and my observation of the patient's kind of motor activities and behavior. There are features of the machine that allow for cardiovascular examinations and stuff like that, but we typically won't use those in our standard visits when we're kind of focusing on the substance use disorder.
Okay, great. Thank you. Okay, is there a limit to the amount of patients that a provider can see per year under this treatment?
I think I can take that question. I mean, as far as the kind of telehealth end of things, I don't believe there's any type of additional regulation surrounding patient caps via telehealth. But just in general, if you're prescribing buprenorphine for the indication of opioid use disorder, you are subject to caps from the DEA, and you have a 30 patient cap in year one, a 100 patient cap in year two, and a 275 patient cap in year three if you apply for those, kind of file the paperwork. And it's not a yearly, the way they actually do the accounting is that at any given moment in time, you can't have a greater number of active prescriptions than those listed for the caps. So that's one of the things that the program, Tina and our program manager, keeps track of, is for each provider, kind of what's their tally, how many patients are they actively treating at the moment, so that they don't get anywhere near their DEA cap. Yeah.
Okay. Then what about with the experience of the provider for the telehealth visits? What's that like as far as being able to assess the patient?
Great question. I'm kind of a Luddite, so I was a little skeptical at first, but I've had my experience. It's been pretty. It's been pretty good technology for, at least for this application, that I've had patients now for a couple of years that I've never met in person, but see every couple of months on telehealth, and I really feel like I get to know them pretty well, and we get to establish pretty good rapport, so I think that for this particular type of medical encounter, where you're really kind of talking and kind of hearing about their experience, I think it's been I've been really pleasantly surprised at the connection we're able to make, and at how successful these visits have gone.
Okay, great. Okay, so there's some questions I think for you, Ron, maybe. How do you see CMS new EM codes for 2019? How do you think those will be integrated or addressed in this scenario? And the comment to that also is, seems like that is more around visits, and this is for opioid use and control substance. Are
Yeah,
the
that's
EMRs?
oh,
Sorry, there's another one to that, but go ahead. I'll let you finish that one.
No, that's I mean, that's an interesting question. So what they're referring to there is there was actually some new CMS Medicare regulations for 2019 that are coming out, and we should know hopefully by the middle of December. And the three main ones are, and some people have already kind of heard about some of this already, is one is that a physician can get a $14 for checking with a patient to see if they need inpatient visits or not, if they need to actually come into a clinic or an emergency room. So it's a way to help clinicians get paid for some of the things they're doing already, which is, you know, talking to their patients on the phone. And the other thing is to basically, of course, to divert unnecessary visits to the physician's office or urgent care centers or emergency rooms. There's, you know, of course, the numbers vary on which study, but I've seen them that said, you know, 68 to 71% of the time they could be avoided. So that's one of them. The other one is basically clinician-to-clinician consultation. That's something else they're looking at reimbursing for. And then another one is basically a video or pre-recorded session from a patient that would be viewed by a provider. As far as I'm concerned, you know, I think you know, there's going to be some overlap and some interaction. I think anytime you have you know, a physician or clinician-patient relationship, these extra items for telehealth will apply to those relationships as well. So I think there will be some interaction, but it's not directly connected.
Okay, great. And then the follow-up part of that was, if EMRs are accepting the codes and prescriptions for these visits?
Oh, that's a great question. So for telemedicine, just in general, for some of you that are new to it, you know, of course, we have Medicare, the federal program, and they have specific criteria. So let's take you know, the prescribing of controlled substance out of it. But with Medicare, you know, there's basically POS codes, place of service. Used to be GT modifiers that you would use. And then, of course, for Medicaid, each state makes its own decision, and 49 states right now reimburse. And then there's actually 38 to 39 states that actually have legislative mandates and parity laws in place. And to get to your point of your question, well, the EMRs, I haven't heard, I guess is the best. I have never heard of someone saying that current telehealth, or let's hope in the future, that they've had any issues with the way their EMRs actually accept the billing codes, because they sort of, when they develop them, they actually just use different Q codes and different codes that are regular, but they just symbolize telehealth. If that answers your question, I think it does.
Okay. Another one. So just to confirm, your patients need to be in a DEA registered clinic, which is most commonly a methadone clinic. Is this correct?
Well, I think there's two sides to it. So there's the 7 exceptions, and as I say, just to give you a you know, a disclaimer, I'm not a lawyer, and every situation is different. There's state law, there's a lot of different things. But if you look at the exceptions, and if you go to the website, if you like Nathaniel Lackman, like I said, and we'll be sending this out tomorrow. I actually put him as the source in the bottom because that's where I got a lot of my information. He has some great things. He has the seven exceptions. And number 1 is treatment in a hospital or clinic. And it says the practice of telemedicine is being conducted while the patient is being treated by and physically located in a hospital or clinic registered under Section 303F of the Act 21 USC 823F by the practitioner acting in the usual course of professional practice, who is acting in accordance with applicable state law, who is registered. So basically, you're registered and you're practicing as a competent clinician within that same given situation if you're in a treatment or hospital or clinic, which is what they're in. So it's not just an actual substance abuse clinic the way that I understand this, but again, as the doctor said, Dr. Darton, you'd want to check with legal on that. I think it's basically any clinic that has that correct jurisdiction as a clinic under the Section 303F of Section 21 USC. So I think it's whatever your designation is. If you're designated as the clinic or a hospital, then you're okay. Dr. Dartner, I don't know if you've seen anything different than that, but
that's my understanding too. Yeah, exactly.
Okay. Yeah.
All right, we have time for one more question. We're approaching 3 o'clock here. This would be for either Tina or Dr. Darton. Do the providers get specific training on delivering mental health services via telemedicine, such as, how to talk into the camera, or here's how you do assess a patient over video, or anything like that?
That's a really great question. We get a training on basically how to use the different functions of the telehealth technology, but we haven't specifically talked about, ways you might structure an interview differently or something like that. That's a really interesting thought, actually. It'd probably be a pretty useful thing to address. Though I will say, I think the telehealth visits compared to the in-person visits that I conduct are pretty similar kind of in structure and content.
Great. Okay, I think we are out of time. It's 3 o'clock, so I want to just thank everybody again for presenting today. I have up here on the slideshow, you should see the contact information for each of our presenters today. Following the webinar, within the next 24 hours, you'll also receive an email which will have a link to the recording of this webinar, as well as a copy of the slides, and of course contact information for each of the presenters if you wish to follow up with additional questions to them or to myself. Thank you again, and have a good day.
Thank you.
Thank you, Carrie. Thank you, Dr. Darton and Tina.
Thanks.
Thanks.